Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today we are dealing with this brown cataract in a 68-year-old lady. And we'll be doing this under subtenon anesthesia. So for now, 1 ml of lignocaine is injected in the subconjunctival space and a flap is being created. Now there were a lot of challenges if we would have opted for doing a phaco. The first thing was the endothelium was compromised. Second, hard cataract. So a lot of energy would be needed to perform a phaco. And on top, breaking the posterior plate is also a challenge. Plus I had at least 1.75 mm of against the rule astigmatism. So that is why I decided to go about doing a small incision cataract surgery sitting temporally. So after giving subtenon anesthesia, a small groove is created which will help me stabilize. Straight incision near the limbus is made so that I can counter the against the rule astigmatism. The scleral tunnel is being fashioned, and once that is done, just go into the cornea and with 2 or 3 swiping motion, the tunnel is ready. Now making an entry with the 2.8 mm steel keratome, a bit of phenocane is injected. Now we need to stain the anterior capsule nicely, as we are not going to get a good red reflex in this brunescent cataract. Leave the dye for at least 10 seconds and then wash. Now injecting 1.8% sodium hyaluronate for all the surgeons in their early stages. If you're using just 2% HPMC, it's always better to learn how to do a rhexis from the side port. It will help stabilize the anterior chamber and help you do the rhexis easily. If you are using 1.4 or higher concentration of OVD, then you can easily do it while going from the main port. Now cut while going in and open up the tunnel. Hold the groove which we made earlier and open it on the left side. So we have a nice large tunnel, a nice large rhexis. Just rock the nucleus, don't do too much of hydrodissection. The nucleus rocks, it will come out easily. And just wheeling it out of the bag. Now 1.4% sodium hyaluronate above and below the lens, and with this irrigating wire vectis, just pull it out. Now not much of cortex is remaining, but first flush out the debris, and this flushing will loosen up the cortex as well, and then you can easily remove it, aspirate it. Now this is a 22 gauge Simcoe cannula, excellent tool. Always clean up the subincisional cortex going through the side port, helps maintain the chamber and gives better accessibility. And now injecting the IOL, the bag is formed. This is a hydrophilic IOL. Do not push the leading haptic straight into the bag, it will pop out again. So first place both the haptics over the iris and then first dial the trailing haptic in the bag. Rotate and bring the leading haptic back at 11 o'clock position. Form the chamber and then dial it in the bag. So now we just need to confirm it's in the bag. Yes, it's in the bag. So now just thoroughly clean up the OVD to avoid any post-operative IOP spikes. I can see some of the cortex at 12 o'clock in the subincisional space. So now that can be easily removed with the IOL in place and cushioning the posterior capsule. So now we have a nice clean bag, nicely centered IOL. We have negated against the rule astigmatism. We were friendly to the cornea as well, endothelium as well. I hope you like this video. Do like and subscribe to my YouTube channel. Thanks for watching.